Good morning, everyone. My name is Janice Podzimic. I am the violence and brain injury advocate for the Brain Injury Alliance of Arizona. And I would like to introduce Dr. Valera. I will read a brief bio. Dr. Valera, Associate Professor in Psychiatry at Harvard Medical School and Research Scientist at Massachusetts General Hospital, has worked in the field of domestic violence for over 25 years using a range of methodologies to understand the neurocognitive and psychological consequences of brain injuries from intimate partner violence. She has authored over 50 publications and has obtained numerous grants to support her research. She regularly lectures internationally and has been interviewed by numerous news sources: TV News, New York Times Magazine, Forbes, USA Today, CBC, Canadian Radio. She is actively engaged in training stakeholders and raising awareness of this global public health epidemic. Let's introduce Dr. Valera.
Thank you so much for that introduction. And thanks to all of you who have signed on this afternoon. I really appreciate your interest in this topic. It's something that I think has been overlooked for a very long time. So I'm going to start to share my screen. Just get this going. And I think everyone should see that just fine. Looks good on my end. And I assume someone will tell me if it doesn't look good elsewhere.
It looks good.
Excellent. So the one thing that I will just open up by saying is that this isn't a fun topic, and it can be difficult for people to hear some of this, especially folks who may have experienced partner violence. And so just putting that out there, I recognize that. I know it's not necessarily fun to hear about things that are very stigmatizing and that maybe you've experienced that you've not even told anybody. So if this is something that's sort of disturbing for you, please take care of yourself and know that there are lots of other folks out there who have experienced similar types of situations. So in short, what I'm talking about today is the idea that repetitive brain injuries are not just for athletes and military personnel. And the folks that I'm talking about who tend to be overlooked are women who have experienced intimate partner violence. So what is IPV, or intimate partner violence? So simply put, IPV is violence perpetrated by a current or former spouse, partner, significant other, boyfriend, or girlfriend. Intimate partner violence is a subset of domestic violence, which can also include elder abuse or child abuse. And intimate partner violence does not just mean it has to occur in the home, like domestic violence might suggest. So if you have a partner who you've been with for a little bit, you've just dated and you've been out and about, if there's abuse of some sort, that's IPV. It doesn't need to be in the home, and it doesn't need to be with a long-standing relationship. So just sort of to understand that anybody who hurts you, who you're having a relationship with in that context, that would be considered IPV. So some really unfortunate facts about IPV are the following. Intimate partner violence is the leading cause of homicide for women globally. So, I mean, one of the saddest things I ever have to say, well, there's a lot of sad things, but if I were to hear that someone was murdered, a woman was murdered, and somebody said, I wonder who it is, my guess, I would have to say, if I were a gambling person and wanted to go with the odds, is that it was a current or past partner. Doesn't matter where you are, that's going to be the most correct answer, the most correct guess by the odds, which I just find extremely disturbing that that's the state that we're in right now, that women are most likely to be murdered by someone that they love and care for or had that experience with in the past. IPV is also the most common form of violence against women. Similar to what I was just saying, this is just an unbelievably horrible thing to imagine, but it's true. And IPV is found across all socioeconomic boundaries. IPV is, really simply put, a global public health epidemic. IPV does not just happen to the people who are over there or the people in this country. Well, yeah, this country doesn't have very good laws against, for protecting women. So of course, IPV violence happens to women there. Or, well, it's only the women in the projects, or it's the people of color. And it is absolutely true that IPV disproportionately affects certain women, women of color, Native American women, Indigenous folks. Any marginalized group of women will be more affected by IPV, but it does not mean that it's not affecting everybody else. And at the end, I'm going to show you just a slide about a woman, a very prominent woman, Harvard, graduate, an author, a very bright woman, et cetera, who tells a story about her experience with partner violence. And it would be in one of those situations where you'd be like, wow, that's, you experienced partner violence. Why didn't you just leave? And that, by the way, is one of the dumbest things anyone can ever say. And it may not be easy to understand why that's not a good thing to say, but hopefully by the end, we'll understand that a little bit better. And when I say dumb, I don't mean dumb as in like you're stupid. It's sort of like the context is, in our society, we have set things up so that we tend to blame the victim. We tend to think, well, why don't you just do this, instead of why doesn't the partner be held accountable? And women are often trapped is the sort of the short answer to why women might not leave. But that's what her story is sort of about. So what are the real numbers? 1 in 3 women experience some, over the age of 15, are estimated to experience some form of physical or sexual partner violence. The estimates change a little bit. So if you take a CDC estimate, it might be like 1 in 4 women. It also depends on what type of violence people are talking to, but we can say 1 in 3 or 1 in 4. And it's not that big of a difference, but this is from a science paper where they did a global study with a lot of different individual studies of epidemiology of IPV. And that's why I choose this number. I think it's pretty representative. And so when we think about IPV and who it might be affecting, what I try to do is I say, okay, let's think. I think most of us here probably know at least 9 women. Okay. And so if you know 9 women, I want you to think not which one, not which 2, but which 3 of those women may have experienced partner violence. Because by the odds, that is the likelihood that you know at least 3 women who have experienced partner violence, if you know at least 9 women, which I think most people watching this probably do. And you might say, well, that's not me because I don't know anybody. And you might be right, because there are exceptions. These are just numbers and averages. But I would bet that most people know somebody, even if you don't know it. IPV is very stigmatizing. It's something that people don't necessarily want to talk about because it may bother them. And they may not want to talk about it themselves because they may think it makes other people uncomfortable as well. And there's not necessarily opportunities to talk about it, or maybe they're afraid to talk about it if they're still in the relationship with the partner. So there's all sorts of reasons why this is a hidden problem that's basically right underneath our noses all the time. And the reason I talk about it like this is not to sort of really beat it home that this is everywhere just for the sake of nothing. I want us to feel like this is something that affects us, because it does. This is not just other people. These are our daughters, our sisters, our mothers, our colleagues, our friends. These really are the people all around us, even if we don't know it. And the reason I want people to understand this and feel this is because that way, hopefully, people will say, wow, I want to be more engaged in this problem. I want to understand what's going on so that I can help the people who are around me, help the people I love. And I think there's power in numbers. So the more we as a society and as individuals, if the numbers grow enough and we push for enough change for how IPV is treated, I think that's where we're going to make a difference. Unfortunately, in intimate partner violence, 80 to 90% of violent abuse to women injures the head or neck. I've had women tell me they were stomped on the head with work boots, punched in the head repeatedly with fists, smashed in the head with hammers, and beat in the head with baseball bats. I'm not just being sensationalistic. These are indeed stories, and these are not necessarily uncommon stories, and these are not the worst stories either. So the bottom line is, if you understand this, it will become clear. And part of the reason I learned this was because I was working at a shelter and I'd hear women's stories. And I was also at the same time learning about neuropsychology. I was learning about how brain injuries can make it harder for people to do things that they need to do, or to think, to behave properly, to have emotional regulation. And then it occurred to me that, well, these women certainly seem to be sustaining brain injuries, but at the time there was really nothing. And I think for a lot of people, they ultimately have that light bulb moment once the two are put together. But for most people, that light bulb moment hasn't happened. That women are hit in the head who are sustaining these brain injuries, and so who are experiencing partner violence. So of course they might be sustaining brain injuries. And so what I found when I started looking at this is that actually, if you go back, the other thing that I noticed in just working with women who'd experienced partner violence was that women experience high rates of cognitive, physical, and emotional problems that are very similar to what someone might see if you're working with someone who had experienced a traumatic brain injury. There are basically examples of post-concussive symptoms. So memory problems, headaches are huge with women who've experienced IPV. Things that may look like irrational behavior or an inability to follow through on things, just sort of general attention problems. And so when you put it all together, it would make sense that they may be sustaining brain injuries. And what I found was that most of the women who I studied in this study of 99 women were indeed sustaining IPV-related brain injury. And if I'm just going to put this in the context of the women who've experienced partner violence in the United States, that would be about 42 million women. So by using that 1 in 3 estimate, we've already discussed, it could be 1 in 4, but so maybe it'll be 30 some odd million instead of 42. It's still a lot, right? Of the 99 women I interviewed, 74% reported at least one brain injury from their partners. And so that would be, if you were to extrapolate these numbers, about 31 million women in the United States alone who may have experienced a brain injury from their partner. That is a huge number. Now, what's even more disturbing is that just over half of these women reported repetitive brain injuries from their partners. So it might be 2 brain injuries, it would be 3, sometimes it was maybe 4 or 5, but for some women it was simply too many to count because they were hit so many times in the head and had and had alteration in consciousness from a brain injury that would extrapolate into just over 20 million women who may be walking around in the United States who have sustained repetitive brain injuries from their partners. Most of these brain injuries will go undetected and undiagnosed. Now, I want to acknowledge that extrapolating like this is not any way to do epidemiological research. These are not epidemiological data, and these could be gross overestimates. But even if you're to cut it in half or in a quarter, so say it's just 12% instead of 51%, that's still what? 5 million women with repetitive brain injuries in the US from their partners. No matter how you slice it, this is a huge problem happening way too much. And we do need good epidemiological data. And we need a lot more research understanding this problem. What I also found was that IPV-related brain injuries in the US were associated with poor cognitive and psychological outcomes. Higher brain injury scores were associated with poor performance on tasks of memory, learning, and cognitive flexibility, and higher ratings of general distress, depression, worry, anxiety, and post-traumatic stress symptoms. So basically, you have more cognitive challenges and higher levels of cognitive distress. And I also found out that it was not accounted for by abuse severity, psychopathology, or substance abuse. So historically, what we might say is, well, women who are experiencing partner violence, they really do seem to have maybe some cognitive problems. Maybe they have trouble focusing, or maybe they say they can't think or remember, and they're depressed, and maybe they have PTSD. Well, that's because they're walking on eggshells, or they've been in this horrible relationship, so it's psychologically traumatizing. And whereas that is certainly true, I still believe that to be true, when we control for other factors, we still see a relationship between the brain injury score, or the number, recency, and severity of brain injuries, and these other variables. So it's not just, and it's not my way. When I say just, I don't mean that in a minimalizing way. It's just, it's not only accounted for by this psychological trauma of being in the abusive relationship. In a more recent study, we discovered, the brain injury information I was giving you was just a study conducted in Illinois in the United States of America. In Colombia, in a city of Barranquilla, Colombia, we found that the prevalence of IPV-related brain injuries was 31%. So that's certainly lower, but still a tremendous number. And the rates of partner violence are higher in that area of the world, if you look at the epidemiological data. And what we found here, again, was that higher brain injury scores were associated with poor performance on tests of long-term and working memory and cognitive flexibility. So very similar to what we found in the United States study. And we also found that the brain injury scores were close, is probably an issue of not having enough subjects. But again, we need more and bigger studies to do this, but a trend level relationship with depression. And so there may be some differences culturally, we don't know, because we just don't really have the data yet. We'd have to do a real systematic study with the same investigators, et cetera, across cultures to really know that. But we are definitely seeing that it's not just in one location or one study. And again, we found that it was not accounted for by abuse severity, SES or education status, or substance abuse in this sample of women from Barranquilla, Colombia. So the next thing I'm going to talk about is brain connectivity. And why do we want to talk about brain connectivity? Well, first, to get brain activity, it's connectivity. It's pretty easy. We just basically put people in an MRI scanner, just like we do if we want to get, a picture, to see if there's damage in the brain or something like that. We put people in an MRI scanner, and we can use special techniques and scans and mathematics to look at how different regions of the brain are communicating with one another. And so, sorry, a little dryness in my throat, apologies. So we can talk about structural connectivity, which is looking at parts of brain cells that connect different brain regions, or we can look at functional connectivity, which addresses regions of the brain that are working together but are not right next to each other. So it could be a region in the frontal cortex and a region in the occipital cortex. And when we look at a brain scan, we can say, oh, they're acting at the same time and frequency with each other. So they're communicating with one another, forming basically a network. So that would be an example of brain regions that are functionally connected. We know that both structural and functional connectivity are critical for optimal brain function and ultimately for behavior. In the past, we would talk about, like regions, and we still do, but regions of the brain, like one's responsible for vision, one's responsible for working memory, one's responsible for touch. And we know that's true, but we also know that the connectivity between the different regions is tremendously important. And when we have concussions or brain injuries, we know that these things can basically cause injuries to the brain cells that can affect the structural and functional connectivity. And so just to give an example of how easily this can happen, this is a neuron that we have right here. And we have the axon here that I've pointed out in red, which is very thin, and in some neurons is very long. And so when you have traumatic forces to the brain, it can cause those axons to twist or turn or get stretched. And so that you can have traumatic shearing of the axon when you have strong acceleration, deceleration, or rotational forces. And if you do have that shearing or breaking of the axons, then that brain cell may not be able to communicate with other brain cells very well, or maybe not at all. And so what you might have is a lot of these axons breaking throughout the brain, and these are microscopic. So it's not something you would necessarily see on a scan. And so you might have what one might call diffuse axonal injury. Diffuse because it occurs throughout the brain, axonal because it's injuring the axon, injury, well, for obvious reasons, because it's injured. And so for the longest time now, we've talked about concussions or mild traumatic brain injuries as potentially being the result of diffuse axonal injury. And so that's just an example of how we can see functional and structural connectivity are important in terms of understanding what may be going on in the brain following a brain injury. And what I found in this one study that I'm going to tell you about right now, really briefly, is that brain injuries are associated with network connectivity, which was also associated with memory and learning. My objective here is not to get into the details of what the brain injuries were, exactly what it means, how to do the stats or anything like that. Because, well, first of all, I don't have a lot of time, but the point is just to sort of show that what has been done in many, many, many studies, in studies that have been conducted on athletes or military folks, and they say, we've looked at this measure of functional connectivity in these NFL athletes, and we find abnormalities in the functional connectivity between X and Y regions. And people say, oh, wow, this is important. We're finding the same types of things here when we actually look at women. We haven't looked at the women that much. In fact, this was the first study that I ever did using neuroimaging. But very simply put, the posterior cingulate cuneus and the anterior insula are nodes in two separate networks that are important for basically advanced cognitive processing. And without going into too much detail, we do know that these two brain regions should be communicating with one another when someone is engaging in a complex cognitive process. And what we found was that the more recent and the greater number of brain injuries a woman had, the less positively those two brain regions communicated with one another. Okay. And then importantly, the less those two brain injuries communicated with one another, the worse women tended to be able to learn a list of words that were read to her 5 times and remember that list of words 20 minutes later. So there is a meaningful outcome for what we're talking about with respect to this connectivity or lack thereof in women who have sustained more brain injuries relative to women who have not sustained any or fewer. And in another study looking at structural connectivity, again, I'm not giving you the details, and I'm happy to give more and specific details to anyone who wants them afterwards, or we can share the papers. But the bottom line here is that I found that IPV-related brain injuries were also associated with structural connectivity in the superior and posterior coronal radiata, as measured by fractional anisotropy. This study was modeled after a study that was done on football players where they're looking at the effects of repetitive brain injuries. So I used data and information from that study to say, oh, can we find something similar in the women who've experienced partner violence? And lo and behold, I did. So again, it's just an example of showing how structural and connectivity can be linked to the number of brain injuries that women have experienced through intimate partner violence. For the next little bit, I just want to talk a little bit about strangulation. Strangulation is very important and relevant here because it's a serious form of abuse that can cause an acquired brain injury or an ABI. Strangulation is not choking. Now, I was just talking to a woman this morning and she said, I was choked. And she used the word choked anyway. And I said, okay, so when you were strangled, and she used the word choked again. And that was fine. I'm not here to say that if a woman expresses that she was choked, that we should correct her or say that's not right. But if we're talking as professionals or an academic setting, we should use the word strangulation because that's really more appropriately what the term is. It's an external attack on the neck versus something that is internally lodged within your windpipe. Okay. And I think using the term strangulation really helps bring out the severity of what's going on versus sort of choking, which, and at least in my view, does not sound as serious. When we talk about strangulation, there are terms that one might hear, and they involve this term asphyxia. And asphyxia is simply depriving the body or cells of oxygen that could lead to unconsciousness or possibly death. And we can have hypoxia, which is partial loss of oxygen to tissue, or we can have anoxia, which is complete absence of oxygen to tissue. And ultimately, strangulation is a form of asphyxia from external pressure placed upon the neck, such that there's an obstruction of blood flow either from or to the brain via the jugular or the carotid artery. So if we look here, the blue is the jugular veins on the most lateral portions of the neck. And if you press on those a little bit without going any further, what you can do is you can block the dirty blood that's leaving the brain, that's been used and now needs to go to the heart and lungs and gets clean. You're blocking that from leaving the brain. And if you still have oxygen-rich blood going into the brain, then you can have blood buildup, basically. You have blood going into the brain, into a space, and there's going to be not enough space for all that blood because you don't have any blood leaving the brain. And so that could result in potential increased intracranial pressure. Now, if you press on the neck a little bit harder, and it's not that much hard, I guarantee anyone in here has the strength to strangle somebody. But if you press a little bit harder, then you can block the carotid artery. And then you don't have the problem where there's too much blood building up, but you don't have the oxygen-rich blood going to the brain. And those brain cells need that oxygen-rich blood every second, or they may start to die or get injured. And so the final way that you can have a form of asphyxia is by blocking the actual trachea. When you press even harder, then you may actually obstruct the actual input of air into your body, which obviously then you can't get oxygen at all. So those are the ways that you can cause asphyxia via strangulation, and it's remarkably easy. Blood buildup or lack of enough oxygen from strangulation can cause damage very quickly. Blood buildup can cause unconsciousness within 2 minutes. Anoxia can cause unconsciousness within 10 seconds. Strangulation can cause brain death while leaving no external mark. So I've heard stories of women saying, well, the paramedic told me I couldn't have been strangled because there were no marks on my neck. And that's a really unfortunate incident because it's clearly not true. And I've had women tell me, well, he likes to strangle me until I go out, then I lose consciousness briefly, and then he brings me back, and then he strangles me again. It's very easy to do. You don't necessarily have to leave marks if you do it the right way, quote unquote. Damage may result in death weeks later. It's not very common, but you could have swelling or carotid dissection that then may result in a stroke, internal bleeding, or respiratory problems or pneumonia. That could be things that don't happen immediately, but as sort of the cascade of events from the strangulation continues, may cause death later. So it's in many, or if not all cases, not a bad idea to basically get treatment or be seen if there's been a strangulation. So in terms of IPV, rates of strangulation vary depending on how it's measured. No matter how you do it, the numbers tend to be high. But if you just say, did your partner ever choke you? That term, remember I said you shouldn't necessarily use if you're talking academically, but women will use it. And so it's a good way to ask women things. And one of the most common forums that we use to ask women about partner violence, one of the questions is, has your partner ever choked you? And in that case, 86% of the women reported at least one instance of being choked by their partner. Now, that doesn't mean that they were choked or strangled to the point where they had what I might refer to as an alteration in consciousness, which could be either a loss of consciousness or an alteration, basically not having memory for the event, or potentially having just diffusion, confusion, disorientation, not quite knowing where you were, et cetera, the things that you might have if you were to experience a brain injury. So if I say after anything your partner ever did to you, did you ever lose consciousness, feel dizzy, feel dazed, confused, etc.? 26% reported at least one alteration in consciousness from being strangled. Okay. And the next thing I did, and this is a paper that was just published, so it's these are pretty new data. What I wanted to see was, well, if we look at that, if we just say, okay, strangulation related alteration in consciousness, does it really mean anything? We look at that in relationship to cognitive and psychological functioning. What I found was that strangulation related alterations in consciousness were related to measures of memory, depression, and PTSD symptomatology. Okay, and that's in this. There's a special issue of Journal of Head Trauma Rehab. So exciting. Angela Colantonio and I were co-editors for the special issue, and it's on basically brain injury and intimate partner violence. So if you want to see a lot of really awesome articles in a special issue, you can check out that issue of Journal of Head Trauma Rehab. So just a little side note, because that was just published. Now, another important thing to think about in the context of IPV are neurobehavioral symptoms. And in another study that we just published, actually in that same issue, we looked at the correlates of neurobehavioral symptoms in IPV because we wanted to see if we would see a connection between other variables that we know women who've experienced partner violence have also experienced. And one of the things that we're interested in was childhood abuse or childhood trauma. And what we found was that childhood trauma was indeed associated with higher levels of somatic and emotional symptoms, independent of brain injury. And so what this is saying is that when we use this term neurobehavioral symptoms, what we really did here is we looked at I'm trying to not use the word, if we were to take like a post-concussive inventory, like the Rivermead or the NSI, and look at the symptoms that people often report following a concussion or a brain injury, and say, okay, well, these could be related to brain injuries that these women have sustained, but I wonder if there's something else that could be going on, because we know these quote unquote post-concussive symptoms are also very common in the general population. And what we found was that indeed childhood trauma is associated with this. So this is just one example of how, even though we talk about brain injury in women who have experienced partner violence, and it's very real, it's very prevalent, and it has a number of outcomes so far that we've identified, it doesn't necessarily mean that all of these symptoms are from brain injury. So unfortunately, women who've experienced partner violence also have, many of them have histories of childhood trauma as well. And we were able to link the childhood trauma histories to some of these. But what we also found was that, brain injury was associated with these symptoms independently of the childhood trauma as well. So it's just to say that there are going to be complex relationships between what we might see in women who've experienced partner violence and what these quote unquote outcomes of brain injury might be, because it might be an outcome of childhood trauma, for example, as well. We also found that post-traumatic stress partially mediated that effect as well. And there's another paper that's coming out as well. So hopefully we'll see that one soon, the next time I talk. So kind of quickly, I just want to address the issue of COVID. I think a lot of people know that COVID has been bad in so many different ways. And already women who have experienced partner violence are often trapped in a very dangerous and terrifying situation. We have things like intimidation, verbal attacks, partners isolating women and basically using loved ones to control the women, abusing authority. Economic control is huge among a lot of these people. And so you have this already going on in IPV, making some basically impossible or next to impossible for some women to leave if they wanted to. And then you put COVID on top of that. And that just really compounded those effects so much more for so many women. So it really caused what I call a clash of two pandemics, which likely resulted in increased levels of brain injury. We know that rates of IPV went up. We had economic stress and uncertainty. We had loss of jobs. We had fear of contracting the virus, the COVID mitigation strategies themselves. So the things that we were doing to try to reduce the spread of the virus, like having, force people to spend more time together, which we know by history ends up resulting in more violence. Women basically having no place to escape, be it a shelter or a friend or another family member, and maybe no place to call for help because shelters couldn't necessarily take people because they didn't know what to do about the virus. And so we saw through COVID that rates and the severity of partner violence increased. We had IPV rates spiking globally. You could look in the UK, you could look in Mexico, you could look at, and you could almost follow the path of COVID and then look and you'd see an article about IPV rates escalating tremendously. We have severity of IPV escalating as well. There are a number of, there's one article that was published locally through the emergency or maybe the radiology department, but basically the number of injury, it wasn't necessarily the number of folks who were coming into the emergency room who were experiencing partner violence, but it was the severity of those injuries were much greater relative to the past 3 years that they had looked at. And then femicide or IPV homicides have really skyrocketed in a number of different places. Again, I think I used the UK and Mexico as examples of IPV rates going up, but the homicide rates went up tremendously as well. And those are just some examples that I just happened to see like in the paper. And so we don't really know what's going on with COVID now, or at least I don't. I mean, it's like, is it over? Is it ever going to be over? I don't know. But we know that in some places of the world, COVID mitigation strategies are still going on. And definitely reduce a woman's ability to escape the violence or leave the situation. And some people may have been more quote unquote permanently or long-term affected by COVID. Maybe they're still not back to their jobs, or they really hit, a pivotal shortfall in like finances or what have you, which puts them in a different place so that now they're really even more economically bound to an abuser potentially. And even if COVID were to end today, quote unquote, like we found a cure, there's not going to be any more COVID, historically, heightened rates of domestic violence service demands are seen a year after the event of the crisis has resolved. So we know that IPV is going to be escalated for at least a little while now. So it's right now, it's even more, it's just so important for us to be recognizing the likelihood of IPV right now. We don't have data on whether or not brain injuries are actually going up right during this time. But if IPV rates and severity are going up, the likelihood that brain injuries aren't going up, I would say is basically 0 to 5%, right? I mean, it just, I basically, I know on my heart it's going up. We just don't have the data because no one's collecting the data. But I think this is really, really important right now. So what can we do? Start the conversation. I was really, really happy to see some articles coming out after COVID saying, oh my gosh, partner violence is this huge problem. It's everywhere and rates of IPV are going up. Let's get more resources for women, etc. But the thing that we didn't see, and to this day, there's only a few articles and some of them have just come out, was the fact that it's not just the IPV that's going up during COVID, but likely traumatic brain injuries in these women from the gendered violence that's going up. And that's really important because if you say, okay, now we know what we're doing, we're recognizing IPV, but you're not interacting, you're not working with women in a way that's recognizing the brain injuries, it's not necessarily going to get the desired effect. You're going to be missing things, interventions aren't going to go as planned, and that's not going to be as helpful. So we need to start the conversation, not just about IPV, but about the possibility that brain injury is happening as well. A really important thing to understand is that traumatic brain injuries unseen behind closed doors are very likely to be misinterpreted or missed. I've heard this many times from people who said, oh yeah, and they kind of think back on somebody who they realized maybe this is what was going on. So if you just sort of open a door, right, and you see somebody, there's a domestic violence situation, and you see someone who is disoriented, confused, distractible, inconsistent with their story, not being very cooperative, maybe seem dizzy or off balance. And then maybe there's, you see beer bottles in the background, or maybe there's some drugs. The first thing I'm going to think, I know, or I would have thought until I started doing this, is, well, there's some bad stuff going on here. This person may be, under the influence, and, she needs to chill out, get sober, etc. And meanwhile, the abuser may be saying, yeah, nothing happened here. It was all verbal. She's off a rocker. It's a very nice, coherent story. It's very possible that she just sustained a brain injury. She's not at all intoxicated, but she seems like she is because of what just happened. And he can give a very intelligible story because he hasn't just sustained a brain injury. And so this is important for paramedics to understand, for police officers to understand, for judges to understand, et cetera. And so I just really can't emphasize enough that if we don't consider the idea that a brain injury may have occurred when somebody has experienced partner violence, we may be really missing the boat on what's happened and doing the people we may be trying to help a great disservice. So guidelines for sensitive interaction, and these are just a few, and I will tell you, these are just really pretty much any guidelines for anyone who's experienced a brain injury. It's not necessarily specific to IPV, but minimize distractions, meet in quiet locations, keep the meeting short, take breaks, avoid loud noises and bright lights. You can imagine, if, for people who've just had brain injuries, these are not fun things. Repeat information to make sure that the woman has understood what's happened, or to give her another chance, I should say, and have her repeat it back. Prioritize goals, make them smaller, and write them out potentially. If a woman comes to a shelter and she's given, 5 things to do, you need to make a police report, you need to get an order of protection, you need to start looking for a job and enroll your kids in school. And then she comes back several days or weeks later and she hasn't done anything. You're like, what? She's just like, I didn't know what to do. And maybe that she just had so much she couldn't get around to doing any one of them. So take a step back and think of how we would take, what would we do for somebody who had just sustained a brain injury? Maybe give them one thing to do, maybe write it out, etc. Talk slowly and to the point, and double check with her to make sure that she understood the information. Make sure she can tell you what you just told her. Brain injuries can definitely make it harder for a woman to survive, escape, or keep her children. It may make it harder for her to assess danger, defend herself from further abuse, to make and remember safety plans. And this is really huge, because if you're sustaining repetitive brain injuries, you may be like, how am I supposed to get out of this safely? I can barely balance a checkbook, and I'm supposed to figure out how to get away from this guy who threatens to kill me if I leave. Go to school or hold a job so they're to be financially dependent, and leave an abusive partner and live on her own for a whole host of reasons. May make it more difficult to access necessary services, such as, and adapt to living in a shelter, for some of the reasons that I was just talking about, and retain custody of her children. And again, I could go into details about any of these things, about how it may make it difficult. In the interest of time, I'm not going to go into all of those. But ultimately, the brain injuries that women are sustaining may effectively contribute to their almost being trapped in the abusive relationships in many, many ways. But it does not mean that a woman is unfit. And I really want to emphasize that, because there has been one case, and I forget where it was, maybe it was in Canada, where the defense did actually, I don't know if they weren't successful, but they did try to use this against the woman to say, oh, well, she has a brain injury, so she shouldn't get the kids, or something along those lines. But I have spoken to other judges who said, yeah, well, if the person is willing, if the abuser is willing to take anger management classes, but she's got a brain injury, then yeah, maybe he would be the better person to have the children, which kind of blows my mind, but nonetheless. So we just have to be very careful about how we relay this information to people and what it really means. If I were riding down the road and fell on my bike and got a brain injury, no one would want to take my kids away from me. I might have problems still, right? I might have problems for a little while if it were a bad concussion, but I shouldn't get my kids taken away from me. In the same way, it shouldn't be the case. That shouldn't be the case for a woman who's experienced partner violence. So my message really is that we need to raise awareness everywhere. I want every person you know to be talking about partner violence. And again, not because I want this to be this, horrible, constantly doom and gloom situation, but I want partner violence to be more normalized. I mean, not in the sense that this is a normal and good thing to happen, but that it's happening a lot. So it is unfortunately kind of quote unquote normal. It shouldn't be normal, but it is much more quote unquote normal than most people realize. And I think bringing that out into the open and getting comfortable talking about it is going to help tremendously, because if something's hidden, there's no way to deal with the problem. First responders, including police and paramedics, for reasons I've already mentioned, court personnel with respect to custody cases, criminal restitution cases, and IPV support staff, because maybe the women who just don't seem to be able to make it in the shelter, they're not really working out, maybe those are the ones who have the brain injuries. And finally, affected women themselves. The women that I've spoken to, I had a woman who, for years she was like worried, she thought she was dementing, she was really just in a very bad way. She read a paper and she was just like, me, oh my gosh, this is me. She reached out to me and her life's basically been transformed. Not that I transformed her life, but her understanding of what was going on and then her ability to work with that in a meaningful way basically transformed her life. Women should understand that brain injuries may be interfering with their ability to function, hindering their ability to escape the abusive situation if they're still in it. And we really don't know what the long-term effects are. And we need to understand that. But certainly with brain injury, more generally, we're not sure what the long-term effects are, but there's a lot of data out there that the effects are not good at all. And we also want people to help women understand there's still hope, because if you don't understand what's going on, you may just think, oh, I'm so stupid, I can't do this, or this, forget it, like I'm hopeless, whatever. But if you start using interventions that other people use who might have brain injuries, there is hope, and that will hopefully help women to see that. So I just want to take 1 second. I'm going a couple minutes over, but this is just an example of one woman who I met. We'll just call her Lily. It's certainly not her real name. In her mid-40s, the partner isolated her, did not let her leave the apartment, smashed her head against doors and walls for no reason, chased her with a shotgun, strangled her, causing petechia, the red spots, made her lie about it, shoved and kept her head underwater on several occasions, threw her off a porch onto hard, dry clay. Those were some of the things that he did to her over a period of a few years. She said for 2 to 3 times per month for about 1.5 years, she would experience being woozy from the abuse. And she woke up from being strangled about 10 times. In high school, she had the reading comprehension of a senior in college. And now, in her 40s, she was sounding out words because they weren't making sense to her when she looked at them. And she had to go to a dictionary for words that she would have known like a million times ago. And she used the word scares her. She had terrible word finding difficulties, forgetting names of people she knew well and had relationships with, forgetting train of thought and talking to others. She was in a loving relationship with a partner who was super supportive, yet she was still experiencing anxiety and panic attacks for no reason. I think she's gotten a little bit better since learning of her brain injury. But the bottom line is this is a woman who had experienced severe head trauma in her abusive relationship. And the likelihood that what's going on here now isn't, I would say that it's very likely that what's going on here is related to her abusive head trauma. Okay, she's in a safe relationship now. But we really can't say that for sure because we don't have the data. But I think we know enough to say that this is something that needs to be studied, and we desperately need attention on this matter. If you want an example of a woman, this Harvard grad who's an author, inspirational speaker, etc., she wrote a book called Crazy Love, and that will tell her story of being sort of trapped in a partner violent relationship. She was lucky enough to be able to get out, in part because she did have resources that a lot of women don't. But it just goes to show that it's not necessarily easy. And even when you have resources, it's not just like you walk away the next day. Remember, every little bit of support helps when we're talking about these issues. And I always encourage people to inspire empathy and action in the next generation. And this is just an example of how it has been playing out in my life and people I know. My niece, who was, I think, 13 at the time, knew what I was doing. She started making these bracelets, which if I were speaking to in person, I would have a bag of them and you could take one. Any survivor or any person with lived experience could take one free of charge, which it has, and there's a note that goes with it that talks about being deserving of beauty, recognition, and hope. And this, many women, I mean, one woman said it was the first piece of jewelry she ever got. And I've seen women wearing these a year after I've given them to them. And then my son basically did a fundraiser through his school. They were using dimes to raise money, it's dimes to dollars. It's supposed to be a little thing. He ultimately, decided women shouldn't be getting hurt. And so started a fundraiser and raised over $300. So things can be done and there is hope. And I think those are the types of things that we would like to do. And I just want to end by saying IPV related brain injuries are very common and they're very dangerous. And it's our job to recognize and intervene. And there's my email if anyone wants to reach out with any questions, and or there is time for Q&A right now. Thank you very much.
Thank you, Dr. Valera. There are a few questions from the chat, if you don't mind. Carla is asking, are the articles you are quoting in this presentation available to the public? I would love to review them and share with peers.
It depends on which articles. I think some are. Unfortunately, some of the articles are published in journals that require a payment. But it does depend on which article you're referring to, unfortunately. Yeah.
Okay.
I can probably, if whoever's asking asks, I can send you a copy of the article. That's not a problem. So certainly email me and I can send you a copy. And then, you could send it.
Thank you.
The only other thing, actually, I'm sorry. The only other thing I will say is because I meant to say it during the presentation and occasionally I just don't, but IPV definitely happened. It doesn't only happen to women. IPV happens, it doesn't matter who you are, what gender you are, if you're gender non-conforming, non-binary, whatever, it happens across the board. I speak about women because those are the data that I have. And women are disproportionately affected relative to men more standardly for a whole host of reasons, which I could, which would take too much time. But I don't say that lightly. And the point is that it's not just women, but there are reasons that I do focus on women in the lectures. And I am doing a transgender arm of my study now, which hopefully will give us more information from a different perspective once we have those data in.
Thank you. Okay, the next, Jamie asked, do you know of any resources about the effect of IPV on children who watch it? And she has a foster son who's 11, who was also physically and emotionally abused, and he witnessed abuse.
We do know that individuals who witness partner violence are more likely to perpetrate partner violence themselves. And I'm not studying the children as much, so I can't, I don't know from my own data. I know in general it's not good for kids. It's not good in the long run. And I would have to look actually, but my guess is it's going to be associated with higher rates of negative psychological outcomes. But certainly it's in the longer term, it increases the likelihood for later perpetration.
Thank you. Carla asks, I have been told by clients that long form neurocognitive tests can be completely overwhelming for those with TBIs, as it is difficult maintaining focus, thinking, etc. Are there any short form tests available for check-ins, especially when trying to parse between intoxication versus TBI?
Oh, that's a great one. I mean, what is it? I'm sorry, this was a client in what kind of a context?
Carla, do you want to unmute yourself and ask?
Yes, so thanks for letting me ask all my questions. For this context, I am with the Minnesota Brain Injury Alliance, and I work right next to our resource facilitation team who works with people with TBIs out in the community who either have not gotten their like neurocognitive test to determine where their sort of problems are with their brain injury. Either they have been people who are homeless and they were then hospitalized and we don't really know how the TBI happened, when it happened, or even a lot of my clients have strokes and they kind of wake up and don't necessarily go to the doctor right away. And so then trying to help them get through all the paperwork to get them on like medical assistance to afford to go and get all of the procedures to kind of record that they have this TBI sometimes involves like a neurocognitive test that there's several questions in a row and can be overwhelming, and half the time the clients might even just say I need to stop and then they don't go back. So I just wasn't sure if there was any way to sort of have short check-ins with clients as we're trying to figure out, did they have a TBI? Is this when they're intoxicated? So I have clients who had both, and see if there's anything that we can do to sort of get an idea of where the lapses are. Sorry, I'm sorry. I guess it's just like 9 questions in one, but
Well, okay, so I think the short answer, unfortunately, is that if somebody is intoxicated, I mean, there's really you're not going to be able to parse out the effects of a brain injury versus intoxication. That's just not going to be possible. I mean, anyone who you want to understand what their cognitive capabilities are, sort of genuinely, they have to be free of, they have to be, totally sober. And then, if they've had a history of substance abuse, it could be from the substance abuse, it could be from post-traumatic stress, it could be from brain injury. There's not necessarily a way to tease those apart. If you have someone right in front of you who appears to be intoxicated, what I'm trying to say is, and I don't know if this is where the question is coming from, so this is why I want to clarify. Don't just assume that they're intoxicated, because I think that's likely the case that has, I would, I don't know because I'm not a police officer, but I would say, don't assume that someone is intoxicated or that that's what's going on or that that's what's causing the problems. Entertain the idea that a brain injury has occurred and find out. So ask the questions. Ask, hey, what happened tonight? Was there any point in time where you had your head hit? Or, were you unconscious at some point? And then say, what happened, when you were unconscious? How did that happen? Or, ask questions about alterations in consciousness or getting your head hit and find out if maybe a brain injury or a strangulation had occurred. And then if that has occurred, you have another piece of information to say, okay, so something is going on here. And if they have, if it seems like they have alcohol in their breath, then maybe they're drinking as well. But it's not just going to be this assumption that this person is intoxicated, so they're not to be believed. And this person who's speaking coherently is the one we're going to believe. But there aren't, in any situation in general, there's not really a way. A lot of the women that I might see, or that you might see, I think, may have experienced both PTSD and a brain injury. And there's not going to be a way to disentangle those. There really isn't necessarily. And I don't think there has to be, but I think what we need to do is recognize that both of those things are there. And it's not like just the PTSD or just the depression or just the substance abuse or whatever it is, because then we're missing a part of the puzzle and we're not going to address the issue as well as we should, as appropriately as we should. Does that make sense?
It does. Yes, that helps. Thank you.
Okay, thank you. And feel free to follow up if somehow I didn't totally get what you were asking.
Dr. Valera, I'm going to jump in now. We're at the top of the hour, so I just want to say a big, big thank you to you for a wonderful presentation. A special thank you to Janice and to Anne for helping us moderate today. An email will go out to everyone next week with a recording. And I'd like to just mention real quick that we're going to have another USBIA webinar. It's going to be Wednesday, August 10th at 2 p.m. Eastern Time. It will be Return to School Following Brain Injury, Promising Practices and Current Research, presented by Melissa McCart. She's the Research Assistant Professor and Director of the Oregon TBI teams at the Center on Brain Injury Research and Training at the University of Oregon. So thank you to everyone for participating today. Again, Dr. Valera, thank you so much, and hope to see everybody again in August.
Thank you. Take care.
Thank you.